femur, proximal, valgus deformity, Varus osteotomy and fixation using the LCP Pediatric Hip Plate 3.5, 110 degrees. In this exercise, the procedure of a varus osteotomy using the LCP Pediatric Hip Plate 3.5, 110 degrees will be demonstrated. The LCP varus plates are available in 2.7, 3.5 and 5.0 millimeters. The 110-degree LCP 3.5 plate has a unique 8 mm offset for osteotomies, with the option of increasing the offset using the instrument for medialization. The proximal plate end features 3 threaded holes for locking screws. The 2 proximal holes are aligned to the femoral neck, and the distal hole is directed into the calcar. The calcar screw must be inserted in order to provide higher angular stability and reduce the risk of primary and secondary loss of correction. The combi holes along the plate shaft combine a dynamic compression unit DCU hole with a locking screw hole. However, compression and locking screws must not be mixed along the shaft. Improved connections between screw and plate, as well as within the cortical bone, make casting unnecessary in the majority of cases. Low-profile plate design and locking construct reduce muscle disruption and soft tissue irritation. Upon completion of this exercise, you should be able to distinguish the various etiologies of proximal femur deformities, describe the special condition in cerebral palsy patients with a serious proximal femoral valgus deformity, describe the functional impairment caused by a proximal femoral malalignment, state the indications for a proximal femoral correction, and perform a proximal femur varus and derotation osteotomy. The clinical indications for proximal femur corrective osteotomy include neurological diseases with hip dysplasia, Perthes disease, idiopathic hip dysplasia, increased femoral anteversion, and post-traumatic deformities, varus valgus malalignment, rotational deformities, flexion and extension problems, and, frequently, a combination of the above. The clinical case shows a high valgus deformity and abnormally contained femoral head in a 10-year-old patient. The abduction view of 30 degrees and internal rotation show good containment of the femoral head. The post-operative X-ray shows the correct realignment of the proximal femur with planned containment of the femoral head. The correction was performed bilaterally. Good healing was achieved at 10 months. The plate was removed 1 year post-operatively. Observe that the osteotomy has been successfully modeled. For fracture treatment or rotational correction, the patient can be placed in a supine or lateral position. However, the lateral position makes a radiolucent table unnecessary. In the lateral position, the leg is raised on a stable positioning block. Intraoperative AP, lateral, and axial image intensification must be referred to after each step of the procedure. In this demonstration, the bone model is positioned laterally. The instruments required include the positioner for aiming block, the aiming block for screws 3.5 mm for LCP Pediatric Hip Plates, the screwdriver, hexagonal, 3.5 mm, the Kirschner wire adapter, the LCP drill sleeve 3.5 for drill bits diameter 2.8 mm, the direct measuring device for Kirschner wires diameter 2.8 mm, the LCP drill bit diameter 2.8 mm with stop, the positioner for osteotomy for 3.5 and 5.0 plates, the instrument for medialization, the positioning plate, triangular, 80, 70, 30 degrees, and the 1.5 Newton-meter torque limiting screwdriver. Note that final tightening of locking screws must be performed with the 1.5 Newton-meter torque limiting screwdriver. The first landmark for the guide wire is the height in relation to the apophyseal line. The apophyseal line of the greater trochanter is marked in blue. The height of the plate entry point is between 8 and 10 mm distally away from the apophyseal line. A red dotted line is marked and represents the entry point height of the plate. Note that the midline of the greater trochanter does not correspond to the midline axis of the femoral shaft, as the greater trochanter overlaps the femoral shaft by at least 30%. It is crucial that the entry point is in the axis of the femoral shaft and not in the midline of the greater trochanter. The correct entry point is verified through AP image intensification. Clinically, planning of a varus osteotomy is dependent on the deformity or underlying disease. The aim of this procedure is to recenter the affected femoral head and achieve optimal containment. The amount of correction can be planned in two ways. First, the functional aspect. The functional abduction internal rotation view on the X-ray shows the amount of correction. Or second, by the anatomical aspect. The planning is based on the actual neck shaft angle. As determined by the preoperative planning, a varus correction of 35 degrees and derotation of 25 degrees is required. For varus correction, the degree of the positioner for aiming block equals the angle of the varus LCP plate 110 degrees used in this exercise, plus the planned 35 degrees of correction, amounting to a total of 145 degrees. The calculated varus correction of 35 degrees is set on the positioner for aiming block by untightening the locking screw on the top of the instrument with the hexagonal screwdriver. The upper hinged part of the instrument is swiveled until the tooth is at the required angle and locked in place by retightening the locking screw. The bone model in this exercise shows an 11-year-old patient with cerebral palsy, CP. There is a very high neck shaft angle of 165 degrees and a severe anteversion of 65 degrees. In this exercise, the femoral neck angle will be corrected to 130 degrees and the anteversion to between 25 to 30 degrees, which represents the average neck shaft angle and femoral anteversion of a child. To identify the anteversion, a 1.6 mm K-wire is inserted on the anterior aspect of the femoral neck. The insertion point is verified under axial and AP image intensification. Clinically, the K-wire is glided along the femoral neck until it contacts the femoral head. Note that, as there is no capsule or periosteum represented on the bone model, the anteversion K-wire might slip. In order to overcome this, the K-wire can be angled slightly upwards so as to create an indentation in the bone, and then insertion can continue at the desired angle. The aiming block for screws is slotted into the positioner for aiming block. The positioning guide wire 2.0 mm is inserted into the corresponding hole of the assembled guiding instrument. Be aware, it is crucial not to confuse the three holes of the aiming block for screws. The positioning guide wire 2 mm within the assembled guiding instrument is brought to the bone at the planned entry point. Be aware that clinically it may be challenging to position the guide wire and assembled instrument at the precise entry point. In order to ensure that the guide wire is positioned at the correct entry point, the assembled instrument is removed. A guide wire is used to create a pilot hole on the bone at the correct entry point. The assembled instrument is repositioned and the guide wire is inserted into the pilot hole. It is crucial that before the positioning guide wire is inserted any further, the correct entry point is verified on the plant level in the AP view, as well as parallel to the anteversion guide wire in the axial view. The anteversion guide wire is removed. Observe that the positioning guide wire establishes the remainder of the procedure. With the guide wire in the correct position, the assembled instrument is repositioned over the positioning guide wire. Observe that the assembled instrument can be rotated clockwise around the guide wire for extension or counterclockwise for flexion. In this demonstration, it is neutrally positioned along the shaft. The first 2.8 mm K-wire for screws is inserted up to the physis. Clinically, the insertion depth would be verified with AP and axial image intensification. In this exercise, the insertion depth is verified by aligning an external 2.8 mm K-wire for screws. The second 2.8 mm K-wire for screws is inserted, and the Kirschner wire adapter is used to complete insertion to prevent contact of the drill chuck with the 2.8 mm K-wire for screws. The assembled instrument for K-wires is removed, and the correct position of all 3 K-wires for screws and the positioning guide wire are verified with axial image intensification. The positioner for osteotomy, which is 8 mm wide, is positioned against the K-wires, and the bone saw is used to mark the bone at this level. A longitudinal landmark is made, forming a crosshair in the bone, which can be used for later realignment if necessary. K-wires for rotation correction are inserted above and below the planned osteotomy. The first K-wire is inserted proximal to the planned osteotomy. The triangular positioning plate is positioned against the first K-wire, and the second K-wire is inserted distally to the planned osteotomy at the required 30-degree derotation angle. The bone-holding forceps is placed onto the proximal fragment to prevent manipulation of the inserted K-wires and is supported by an assistant. The bone saw is used to perpendicularly dissect the femoral head at the osteotomy mark. Once the osteotomy is completed, the proximal fragment is positioned lateral on the femoral shaft. 2 LCP drill sleeves 3.5 for drill bits diameter 2.0 mm are attached to the proximal holes of the 3.5 mm LCP plate 110 degrees and tightened with the positioner for osteotomy. The plate with attached LCP drill sleeves is passed over the guide wire and both K-wires for screws. Note that the bone saw is used to cut an edge off of the femoral head segment to facilitate fitting to the plate angle, as the bone model is made out of hard plastic. Clinically, it is also sometimes necessary to cut an edge off of the femoral head segment to facilitate fitting to the plate angle. It is crucial that the proximal guide wire remains in place until the locking screws have been inserted, as the plate must be fixed to the bone with at least 2 anchoring points. The direct measuring device for Kirschner wires, 2.8 mm, is passed over the proximal upper K-wire. Observe that the measurement device must be rotated to obtain the correct measurement. Here, the screw length is 60 mm. The first K-wire for screws is removed and the LCP drill sleeve 3.5 is removed using the positioner for osteotomy. A 60 mm locking screw is initially inserted under power and final tightened with the 1.5 Newton-meter torque limiting screwdriver. The screw insertion steps are repeated, and here a second 60 mm locking screw is inserted. The guide wire is removed. The LCP drill sleeve 3.5 is attached to the calcar plate hole. The LCP drill bit 2.8 mm with stop is used to drill the hole into the femoral neck. The LCP drill sleeve 3.5 is removed, and the locking screw insertion steps are repeated. Here, a 40 mm screw is inserted. Note that the 3 proximal screws for the 3.5 mm LCP plate must be locking screws. Observe that the 3.5 LCP plate is now completely fixed to the proximal fragment. Derotation of the distal femur is performed by aligning the K-wires, and the plate is aligned to the femoral shaft. Once the optimal correction is achieved, it is held in position with the reduction forceps for plates. If locking screws are planned, the LCP drill sleeves 3.5 are attached to the most distal and proximal shaft plate holes. The LCP drill bit 2.8 mm is used to drill both screw holes. The depth is measured directly from the drill bit. Here, both screws are 26 mm long. The screw insertion steps are repeated. Once definitive fixation of the plate has been achieved, the rotation guide wires are removed. Note that the gap left by the osteotomy is not problematic and does not require augmentation. Be aware that if medialization is planned, the screws used on the plate shaft must be locking screws. The required offset of 4 mm is set on the instrument for medialization. The plate shaft screws are loosened. The instrument for medialization is inserted into the central shaft screw hole and the plate pushed down towards the bone until the tooth of the instrument for medialization contacts the bone. The locking screws on the plate shaft are sequentially retightened and the instrument for medialization is removed. Observe that the plate stands 4 mm off the bone. The LCP drill sleeve 3.5 is inserted to the central plate shaft screw hole. The LCP drill bit 2.8 mm is used to drill a hole. The LCP drill sleeve 3.5 is removed and the depth is measured. Here, a 30 mm locking screw is initially inserted under power and final tightened with the 1.5 Newton-meter torque-limiting screwdriver, fixing the plate parallel to the bone. Note that if additional medialization is performed, it is recommended to insert 3 locking screws. If more medialization is necessary, the previously inserted locking screws may require replacement by longer screws. Observe that the osteotomy is stable and combined with increased medialization. Note that the 3.5 mm LCP plate is an angle-stable device and allows a variation of additional varus or valgus angulation of 15 degrees without removal of the proximal neck screws. In this exercise, an increase of the valgus angle will be demonstrated. To increase the neck shaft angle and reduce the amount of varus, the most proximal plate shaft screw is removed and the distal screws are loosened. Note that a higher neck shaft angle is more valgus, while a lower neck shaft angle is more varus. The proximal femur fragment is repositioned to the desired neck shaft angle. The LCP drill sleeve 3.5 is inserted into the proximal plate locking shaft hole and the LCP drill bit 2.8 mm is used. The depth is measured directly from the drill bit. And here, a 40 mm locking screw is initially inserted under power and final tightened with the 1.5 Newton-meter torque limiting screwdriver. The remaining plate shaft locking screws are retightened if the additional correction is not over 5 to 7 degrees. If further correction is required, the middle and distal screws must be replaced and realigned. Observe that the plate is stable and now locked at the desired neck shaft angle. Note that this procedure can only be performed using locking screws. You should now be able to distinguish the various etiologies of proximal femur deformities, describe the special condition in cerebral palsy patients with a serious proximal femoral valgus deformity, describe the functional impairment caused by a proximal femoral malalignment, state the indications for a proximal femoral correction, and perform a proximal femur varus and derotation osteotomy.